Hi everyone. So welcome to this session of one shot ENT. So today we'll do ENT in just over 2 hours. We'll complete. So if you have any questions or doubt, you can write in the YouTube channel and I'll be able to answer all these questions. So very quickly, we'll be very fast. Now we'll start with ear, then we'll talk about throat, and then we'll talk about nose and sinuses in that sequence, right? And in all the three, anatomy is going to be of vital importance because in ENT, they really ask you questions on anatomy. Okay. So now when I draw ear anatomy, see, I draw the ear like this. Let's say this is pinna auricle, then there is a canal which is called the external auditory canal. At the end of the canal there is a membrane here, and this membrane is called the tympanic membrane, we all know, meningus. Then there is a small cavity like this, middle ear cavity. Inner ear I draw like a circle like this, and from here the eighth nerve carries the signal that travels via the brainstem. Brainstem is a very important part of the auditory pathway to go to the cortex where the fine sound is finally heard, right? So this is the auditory pathway. Okay. Now in this auditory pathway, as far as anatomy is concerned, few important things. Number one, a tympanic membrane. Now you should be able to identify a normal tympanic membrane which looks like this, and you have to know 2 or 3 things. You have to know the shape of tympanic membrane, which can be called oval shape. But the 2 very important MCQs from the tympanic membrane, one is the color. Color is an MCQ, they ask you many times, and this is slightly controversial question. The better answer is pearly white. Pearly white color. If pearly white is not given, gray is accepted as an accepted answer, right? And rest of the things in the tympanic membrane you should not be bothered about. Now if they give you the image of the tympanic membrane, which is shown like this, in this image of the tympanic membrane which is pearly white, you should be able to identify this structure which is almost always seen in a normal tympanic membrane. This whole thing is the malleus. The first ossicle is called malleus. This is the malleus. Now in the malleus, you should be able to identify 3 things. One is this one, this part of the malleus, then this part of the malleus, and this part of the malleus, the tip. The top part of the malleus is called lateral process of the malleus. So please identify lateral process. Then the big part is called the handle of malleus, and this tip, this lower point tip, is called the umbo. So in the malleus you should be able to identify these 3 things: lateral process, handle, umbo, and incidentally all the 3 are landmarks of tympanic membrane. They are called landmarks. So when they ask you landmarks of the tympanic membrane, all the 3 becomes the landmark of tympanic membrane. So that's the only important thing in the anatomy of the tympanic membrane that you should spend your time with. But when they ask you anatomy question from the ear, it is predominantly the middle ear. Now if I ask you what is the shape of middle ear, then middle ear can be defined as a box shape, like a room. The room that you are sitting in is like a box shape, isn't it? So middle ear is like that. Why is middle ear called box shape? Like, because any box has 6 boundaries. Now look at the room that you are sitting in. There is a roof at the top, there is 1 boundary, then below there is a floor, second boundary. Suppose the wall that you are facing, the wall in front of you is the outer wall, third boundary. So the wall behind you becomes a posterior wall. So there is, in front is the outer wall, behind is the inner wall behind. On your left hand side is the anterior wall, on your right hand side is the posterior wall. So 6 boundaries. There is roof, there is floor, there is outer boundary, there is inner boundary, there is anterior boundary, there is posterior boundary. Now out of the 6 boundaries, 1 boundary is tympanic membrane that you see on the screen. So if I remove the tympanic membrane, which because we have already done tympanic membrane, then there are 5 boundaries left. Which are the 5 boundaries? There is roof, there is floor, there is outer, there is inner. Outer is gone, tympanic membrane, there is anterior, there is posterior. Now if you take any box, dabba, if you remove one boundary, tympanic membrane, the outer boundary is removed, 5 boundaries left. If you open the box should look like this. This is how any open box will look like, isn't it? Right. Now, so this becomes, let's say, your roof, this becomes your floor. If this is your inner wall, this is your anterior wall, and this is your posterior wall, right? Now, out of these 5 boundaries, because one boundary tympanic membrane we are supposed to have removed, few things that you have to know, that roof has a name. The roof is called tegment tympani. So remember this very important MCQ, the roof of the ear is called tegment tympani. Now on the anterior wall, there are 2 important openings. There is a small opening and there is a large opening. The small opening is called canal for tensor tympani muscle. And this big opening is the opening of eustachian tube. Now eustachian tube is important. From the eustachian tube, there are 3 or 4 very important MCQ which I will tell you. But before that, inner wall. On the inner wall, I'll write here inner wall, which is also called the medial wall. I always say that inner wall you should read or remember as 3 twos, 2, 2, 2. What are the 3 twos? There are 2 bulge, 2 windows, and 2 more things. This is how I suggest that you remember the inner wall, 2 bulge, 2 windows, 2 more things, 2, 2, 2. That's how you can remember. Now which are the 2 bulge? One bulge is called promontory, bulge of promontory, and the second is the bulge of lateral semicircular canal. There is a bulge of lateral semicircular canal. So these 2 bulges, right? So one bulge is like this. This is a bulge of promontory. Right in the center of the inner wall, there is a big bulge. This is a bulge of promontory, and the bulge of the lateral semicircular canal, lateral SC canal, is in the top corner here, like this. I draw it like this, bulge of the lateral canal. And you should be able to identify if they show you the bulge of the lateral canal. Then, as somebody rightly said, Pratyusha rightly says that the 2 windows are the oval window and the round window. And the 2 windows are called such, oval and round, because the shape is like that. So oval window is here, oval shape, this is how I draw the oval window, and round window is here, shape is round. Oval window and round window. And what are the 2 more things? 2 more things are, 1, facial nerve, and fistula antefenestrum. Facial nerve and fistula antefenestrum. So 2, 2, 2, that's how you remember. Facial nerve runs above the oval window like this. This red thing that I have drawn is the facial nerve. As you can see, the facial nerve comes on the posterior wall and goes down. And in front of the oval window, there is a small fistula here. I am showing with an arrow. This fistula that the arrow is pointing at is called the fistula antefenestrum. So these are the things on the inner wall of the middle ear. That's how you remember 2, 2, 2, 2 bulge, 2 windows, 2 more things. And finally, the posterior wall. Now posterior wall is very busy wall. One thing you can see, there is a facial nerve, isn't it? This facial nerve is on the posterior wall. It comes after the foramen here. There is a foramen called stylomastoid foramen, and this is very important MCQ. Facial nerve comes out through what is called stylomastoid foramen, which is this foramen. Okay, so the lower part of the posterior wall has a foramen. In the upper part here, there is a door. This thing that I have drawn now is the door. The door is called the adytus. Now on either side of the facial nerve, there is FR on this side, there is ST on this side. One side is FR, one side of the facial nerve is ST. FR stands for facial recess. FR is facial recess and ST is sinus tympani. Just remember this name if you can. But now comes the most important thing on the posterior wall. There is a pyramid, a bony projection. Pyramid is a pyramid shaped like bony projection with a muscle called stapedius muscle. Pyramid with the stapedius muscle. So where is this pyramid? There is a small bony projection just below the turn of the facial nerve. Can you see the facial nerve is turning? Below the turn here, there is small bony projection like this, and this bone is called the pyramid, and from this pyramid like bone, a muscle is coming out like this, and this muscle is the stapedius muscle. So in one diagram, I have shown you all the important structures of the middle ear, right? So if you can remember these structures, by and large, when they show you the image, the answer will be, they will ask you one of these things only, right? And of course, 3 ossicles. Now, out of these things in the middle ear, you have to know 2 things. You have to know eustachian tube in a little more details, and you have to know stapedius muscle in a little more details. That's all. Details of these 2 things. Now, what are the things you have to know about eustachian tube? I told you in eustachian tube you have to know maybe 3, maybe 4 points. A, the length. Eustachian tube is 36 millimeters long, and it is made up of outer 1/3 is bony and inner 2/3 is cartilage. Okay, so different part of the eustachian tube is made up of different things. Then how is a tube of a child different from adult? Now this is a very, very important point. How is the tube of a child different from adult? A child's tube as compared to adult is shorter, it is wider, and it is straight. Straight means more horizontal. Okay, so the tube of a small child is shorter, wider, straighter as compared to adult. Very, very important point. Remember this extremely important point. And finally, function. Why do you have the eustachian tube at all? Eustachian tube has 2 functions. One is balance the pressure of the middle ear, and drainage of secretions. And when the eustachian tube gets blocked, both these functions get disturbed. There can be no balancing, there is no drainage. When there is no balancing, then it causes negative pressure in the middle ear. And when there is no drainage, there is a collection of fluid in the middle ear. Negative pressure does 2 things. It causes retraction of tympanic membrane, and it causes barotrauma. These are the 2 things that happens because of negative pressure in the middle ear, barotrauma and retraction of tympanic membrane. And if this collection, if the fluid starts collecting, it causes otitis media. So see, lot of points to remember related to eustachian tube. So eustachian tube, they really ask you questions, so be aware, right? Stapedius muscle, you only have to know the nerve supply, which is a branch of seventh nerve. A branch of seventh nerve called facial nerve supplies and function. This is very important. Why do you have the stapedius muscle in the middle ear? It dampens loud sound. Dampens loud sound. What is the meaning of dampen? That when the sound is too loud, if there is a very loud sound because of any instrument, somebody shouting, there is music playing, that get damage the cochlea. So it will decrease the loudness. So it is protecting your cochlea. Basically protects cochlea. In other words, it protects cochlea. But sometimes it is absent reflex. The reflex is absent. It cannot protect, and this condition is called hyperacusis. So you have to know the meaning of hyperacusis. Hyperacusis means stapedial reflex is not functioning, right? So this much about the main things in the middle ear. These two, this slide is very important for you. Remember this slide. And finally in the middle ear, ossicles. Now ossicles, there is malleus, then there is incus, and which is joined to stapes, isn't it? Malleus, incus, everybody knows this, so I don't have to draw the diagram also. Now what is important in the ossicles? The name of the joint. The joint between malleus and incus, this one, between malleus, this is a saddle type of joint. And the joint between the incus and the stapes is the ball and socket joint. So these are the two things that you have to remember regarding ossicles. That's it. Right. So this will complete all the important points about the middle ear anatomy that you have to know in brief. And inner ear is called labyrinth. So this is the membranous labyrinth. And this is bony labyrinth. In membranous labyrinth, you have to know this cochlea. This is the cochlear yellow thing, has 2.5 coils. Very important point. How many times the cochlea is coiled like a snail? It is 2.5 times. This is one thing you have to remember. Second thing you have to remember, what is the fluid in the membranous labyrinth? It is endolymph. Membranous labyrinth has endolymph. And what is the fluid in the bony labyrinth? Between the membrane and the bone is the perilymph. So there are two fluids in the inner ear, perilymph and endolymph. And from here, one very important MCQ, that what type of fluid, what is the main ion of endolymph? The main ion of endolymph is the potassium ion. Remember that. They don't ask you the ion of perilymph, which is sodium basically, but endolymph ion they really ask you, right? Now then obviously in the cochlea there are hair cells, and cochlea has 3 compartments: scala vestibuli, scala media, scala tympani. The sensory organ of hearing, the sensory organ of hearing is called organ of Corti, and it has 2 main types of cells. There is inner hair cells and there is outer hair cells. And they ask you the main difference between inner hair cells and outer hair cells. So I'll tell you only 3 or 4 out of 6 differences. Inner hair cells are flask shaped. They are single row. They produce no emission, not damaged easily. Right. Outer hair cell is tube shape. They are arranged in multiple rows, not single. They produce autoacoustic emission and they are easily damaged. So these are the difference between the inner hair cells and the outer hair cells that you have to know. So with this we'll complete all the important points in the anatomy of the ear that you should know. And then we come to a very important topic of the ear, investigations. What are the common investigations? You know that because ear has two functions, hearing and the other is balancing. So we have investigations for both the functions, hearing also. They are called the hearing test. You can see the first row, they are called the hearing test. And the second column is the balancing test. Now hearing test, the names are very popular names: tuning fork test, audiometry, tympanometry, Barra, autoacoustic emission, and they are all very important also. So we'll discuss most of them. In the balancing test, some of the names are common popular names, some may not be very popular for you, but we shall discuss all of them, right? But try to remember the names at least. We'll discuss only the first two, but you should know the name of all of them: caloric test, fistula test, electronystagmography, optokinetic test, hint test. VEMP stands for vestibular, evoked, myogenic, potential, all the names. Now, two things in the onset. Number one, it's a very popular question: what is the most commonly used frequency in a tuning fork test? The most commonly used frequency in a tuning fork test is 512 hertz, right? And this test are divided into these two. The first two, they are called subjective type of investigation, and these next three, they are called objective type of investigation or test. And don't take it lightly. They really ask you, they'll give you the names and they'll ask you which is the subjective test, which is the objective test. These kind of test question they ask you. Now obviously these tests are not very easy, very simple. You have to know the basics, but this is a revision test. I cannot tell you the basics. If you don't know the basics, you have to go back to your drawing room, you have to go back to your class notes, read them. I will just tell you very fast what are the questions they ask you. If you understand the questions, well and good. If you don't understand, that means you don't know the basics. Then you have to either go back to your class notes, or if you have app, eGurukul app, you can watch that video. If you have not watched the video, if you have eGurukul app and if you have not watched the video, I will highly recommend watch the video at least of tuning fork. Tuning fork का वीडियो जरूर देखना, अगर क्लास के नोट जरूर पढ़ना. इसमें से क्वेश्चन जरूर आते हैं and they are not very easy questions. But I will just give you the questions, two questions that they ask, type of question they ask in the exam. If you don't want to read, just remember the question that I will tell you. अगर क्वेश्चन आएंगे तो वही दो आते, और कुछ आता नहीं है. Now these are the names of the tuning fork test. Everybody knows there are 8-9 tests, but the three names that you know are Rennie's, Weber's and Swaback's, which is also called ABC. Now let me ask you the type of question they ask you. A, the question goes like this: on the right ear, and this is the left ear. In the right ear, Rennie's is positive. Left ear also Rennie's is positive. Positive Rennie's is when AC is more than BC. This side also AC is more than BC. Okay. In both the ears, the Swaback's is reduced. This is how we show reduced Swaback's. This side also reduced Swabax. And web bus is going to the left side. Web bus, so when we show arrow on the left side like this, web bus is lateralized to left side. So there is a finding of Rennes, there is a finding of Swabax, there is a finding of web bus, and based on all the three tests, what is the problem in this patient? Is it normal? Is it CHL? Is it SNHL? What is on the right side? What is on the left side? I really want you to answer this question. Please answer. What do you make out of this? When you have Rennes positive in both the ears, Swabax is reduced in both the ears, and web bus is lateralized to the left side, then what do you think is the problem in this patient? Please comment. I am waiting for your comment. Please write. Anybody wants to comment on this? Now, I can see Pratashu says right SNHL and Blas says SNHL, but you are not saying which side. Now, whenever you reduce Swabax, then it has to be SNHL. SNHL is the only condition where the Swabax is reduced. And this side also Swabax is reduced, so it is SNHL. This side also. So the answer is bilateral SNHL, because both the side the Swabax is reduced, so both the side it is SNHL. Now the second point in this is, if it is bilateral SNHL, then web bursts will always go to the worst side. So I am writing here in SNHL, in bilateral SNHL, web bursts lateralize to worse side. That means the side which has more SNHL. So left has a right, sorry, in SNHL web burst lateralized to better side. Please make a correction here. Sorry, better side. In CHL it goes to worse side. In SNHL it goes to better side. So right has more SNHL. This is a complete answer. Okay. So with this tuning fork test, that you have to say bilateral SNHL, right has more SNHL. Now if you understand this basics, you know how to calculate this, then well and good. If not, I will request you once again that go to your class notes, try to read those notes again, you will be able to figure out. If you don't want to do that, or you feel you cannot do this, just remember, if this is the question, this is the answer, to make it short. Second question, another very important MCQ. This is the right ear, this is the left ear. Right is positive Rennes, which is AC more than BC, but left is negative Rennes, which is BC more than AC. Right is positive Rennes, left is negative Rennes, and Swabax is not given. Web bus is like this. Swabax lateralized to right side. So now what is your answer? What is your answer? You want to answer this one? And this question is also a very popular question, and you should be able to answer this one. So I can see your drug of choice is left CHL, which is not true. In CHL, if it is negative BC more than AC, it can be CHL, but in CHL, web bus will go to the same side like this. This is matching with CHL, but this is not matching with CHL. So this is left severe SNHL. This is your answer. In left severe SNHL, you have negative Renes, but Weber's on to opposite side. See, Weber's is going to the left, left is negative, but Weber's is going to the right side. So this is left severe SHL. Shivam got it right, left severe SHL, and Manoj is correct, which is false negative. So all these are correct answers. So if you know your tuning fork, well and good. If you don't know the tuning fork, just remember these two questions. 9 out of 10 times if they ask you a question, it is one of the two questions. You can check the history of tuning fork questions either in NEET PG or in your exam. They will either ask you this question or the previous one, this question. Okay, so that's all. Now tympanometry is very simple. Audiometry, tympanometry. Tympanometry is a subjective investigation, objective investigation, and the frequency that is used is 220 hertz. Okay, but all this is not important. What they ask you, types of tympanogram. Out of 5 types of tympanogram, I will request you to remember 3 out of 5. A, S type, B, which is called flat type, and C, which is called negative type. You can ignore the rest of the two. AS type of tympanogram is seen in autosclerosis. B, which is called flat tympanogram, is seen in serous otitis media, and C, which is negative type, is seen when station tube gets blocked. Right. So these are the 3 types of tympanograms that you have to know properly. And rest you can ignore. If you know these 3, you know your answer, you know your points. And finally, BERA, which is called brainstem evoked response audiometry, and OE, which is called auto acoustic emission. One thing about auto acoustic emission, if you remember, I told you already, it is produced by the outer hair cells of the cochlea. When we are discussing the difference between inner hair cells, outer hair cells, at that point in time I told you it is produced by the outer hair cells of the cochlea, isn't it? Now, what are the uses of these two investigations? There are 2 uses. In children, they are used to screen or confirm hearing loss. This is the use in children. They are used to screen or confirm hearing loss. In adults, they are used to differentiate cochlear disease versus retrocochlear disease. So this is the use of BERA and OE in adults, and in children the aims are different. So this will complete all the important hearing tests, the main points that you have to know, right? And then we start with diseases of the ear. We'll start with infective disease of the ear, infections. So in the external ear, the only important infection that you should know is malignant otitis externa. In malignant otitis externa, you have to know 5 points only. Very simple, but it is a very important topic. I'll tell you, It is an extremely important topic. They ask you question from malignant otitis externa very commonly, but fortunately they only 5 points, so it's a very simple topic. One, it is seen in diabetics, in elderly diabetics. This is 1 point. Second point, it is caused by Pseudomonas. And third point is that on examination, there is very important thing, granulations in the external auditory canal. So these are the features of tuberculosis, malignant otitis externa, right? Two more questions coming up. Investigation, there are two questions. If they ask you the most common investigation done, then it is CECT, contrast enhanced CT scan. But investigation of choice is technetium 99. And finally, drug of choice. Third generation cephalosporins. This is the answer, third generation cephalosporins, but we always add anti-diabetics also. I can see, so this is about malignant otitis externa, the main points. This is what you have to remember, and don't waste your time reading anything else in this particular disease. And this is the only disease from the external ear that they ask in the exam. You can check your history of exam और किसी topic से question नहीं आता except this one. But this one is asked very commonly. I've already told you. Now I can see a lot of people saying that HIV, AIDS, neutropenia, all these things. That is partly true, because diabetes से क्या होता है? Diabetes causes immunocompromised status. But you know what? Very interestingly, in malignant otitis externa, it is very specific that it is very rarely seen in other causes of immunocompromised patient. Either patient is immunocompromised because of steroid, because of neutropenia, because of AIDS, then malignant otitis externa is very uncommon. It can happen, it is not common. But in diabetics, it is very common. That's why if you read your proper books, proper ENT books, they don't say it is seen in immunocompromised or in AIDS, in steroids and all that. They say it is specifically seen in diabetics. Always, this is what is written in books. So that's why I mentioned diabetics. So that's why I say that don't waste your time reading useless things. And then we come to our main topic, middle ear infections. Middle ear infections means ASUM. So in the middle ear, we'll discuss these three conditions: ASUM, otitis media with effusion, tuberculosis. After that, we'll talk about these two: safe CSOM, unsafe CSOM, 5 diseases. So in future, from here on, I will make a lot of columns like this. Okay. And my dear friends, the aim of making so many columns, I will only mention main points. So it helps in two ways. When you compare these 3 diseases, or in the next one, in this one, if you compare these 2 conditions, it is very easy to remember when you compare. Number 1. Number 2, it takes very short time. It saves a lot of time when I teach you. So the class will be over very fast. I don't have to give you 4 hours, 3 hours and all that. You'll see I'll finish my class less than 3 hours. And I'll tell you everything. In less than 3 hours, 2.5 hours, I will tell you every important point that you have to know. And the third point, when you revise after the class, before your exam, you can revise the whole ENT in 1 hour. And so you can, in one day, if you give half day to ENT, you can revise 5 times from these notes. That's why I'm telling you, please make the notes of your own. Although I will give you a PDF file at the end of the class, but I will suggest that I will highly encourage that you make your own notes. Okay. Now starting with ASUM, now let's compare. What are the comparison? Few points like cause. ASM is caused by strep, pneumonia, Haemophilus, influenza, and Moraxella catarrhalis. Moraxella. Otitis media with effusion has no pathogen. And tuberculosis, I don't have to tell you, Mycobacterium. This we know. Second point, the main presentation. All the three will have hearing loss. This is hearing loss with pain. So hearing loss and ear pain. The next one, only hearing loss and nothing else. In the third one, painless, watery discharge and hearing loss. Hearing loss has to be there. Any ear disease will but cause hearing loss. And so all the three have hearing loss, but here the pain, here nothing else, here watery discharge. And now comes the main thing in all these three diseases. Main thing. What are the main findings? Findings in this thing. In the first one, the main findings, I'll tell you the main finding only. Bulging, red tympanic membrane. At the end of ASM of the otitis media, I will show you the images also. Images will come a bit later, but they will come. There is something called cartwheel. There is fluid level. There is lighthouse sign. And few more things, but these are the things that you have to remember. In otitis media with effusion, there is retracted tympanic membrane. There is air bubbles and foreshortened. In tuberculosis, there are multiple perforations, and there is pale granulation. So the findings are very, very important in all the three. So please pay special attention to the finding. Now, investigations. In the first one, we don't do any investigation. In glue ear, investigation of choice is tympanometry, and I've already told you it is B type tympanogram. In these two, we don't do any investigations, not required. And finally, the treatment of choice. In all the three, in the first two, treatment of choice is very important. In the last one, treatment of obviously ATT. What will you do? Anti-tubercular therapy. So they don't ask you this one. It is obviously any tuberculosis anywhere in the body, you have to give ATT. But in the first two, the treatment of choice is very important. In ASM, when they ask you the first line of treatment, it is AMB. AMB means antibiotics plus nasal decongestants. This is the treatment, antibiotics and nasal decongestants. If they ask you the treatment of choice, which is a different question, then you have to add myringotomy plus the first two. So you have to be careful about the language of the question. Is it antibiotics and first line of treatment or treatment of choice? In serous otitis media, treatment of choice is a very, very, very popular question. Very popular. And the answer is myringotomy plus grommet insertion. This much most people know, but lot of people do not remember adenoidectomy. So remember, without adenoidectomy, it is never a complete answer. So if they ask you the treatment of choice for glue ear, serous otitis media with effusion, these are all same diseases, then myringotomy with grommet with, look at the choice with adenoidectomy, and that is a correct answer, right? So these are the three acute diseases of the year. Tuberculosis is not acute, it is chronic, but these are the three very important otitis media, out of which the first one is least important. They don't ask you ASOM so commonly, but the next two are very, very, very important. Glue ear, serous otitis media with effusion, very commonly asked, especially the treatment, and tuberculosis, mainly the features, multiple perforations and pale granulations, very commonly asked. So what I'm trying to say is, if you don't have time, you can ignore this one. By and large, don't ignore it if you don't have time at all, but you have to know this one and this one, right? So just read them. 1 second, let me switch on the fan. And then we talk about CSUM, and we all know that CSUM can be safe and unsafe, and they ask you the difference between these two safe and unsafe CSUMs. I will tell you the main ones. Both are caused by Pseudomonas. Both have caused by Pseudomonas. Now, safe CSUM has a non-smelly, copious discharge. Unsafe has foul smelly and scanty discharge. So this is the first difference, that one is copious discharge, one is scanty discharge, one is foul smelling, one is not smelling. Now this one has central perforation. This one has either marginal or attic perforation. Both the CSUMs are caused by Pseudomonas, same pathogen. And treatment of choice is myringoplasty, and treatment of choice is MRM. MRM stands for modified radical mastoidectomy, right? So these are the main difference between safe and unsafe CSUM. Okay. Now I'll tell you 2 or 3 more features which are not seen in safe, which are seen in unsafe only. Like unsafe has red granulation, safe does not have. Unsafe has cholestoma, safe does not have. Unsafe has more complications, safe does not have. So out of 8 differences, I am giving you 6 differences that you must remember, the main ones. The first 3 are very, very important. The next 3 also, if you can remember, well and good, which are all features of unsafe, not in safe. No, my dear friend, cholestoma does not have the malignant potential. Don't make that mistake. Unsafe or safe or cholestoma do not have the malignant potential. Wrong information, absolutely wrong. They behave like malignancy. There is a difference between behaving like a malignancy, having a potential like a malignancy. No, they don't have potential, they can behave like one. So there's a difference. But what is a cholestoma? Cholestoma is a feature of unsafe CSUM, right? It is defined as a sac of keratinized squamous epithelium, and the most common site is a site called Prusack's space. And there is a theory, there are many theories trying to explain cholestoma. The most common theory is called Whitmack's theory. It is also called negative pressure theory. It is also called retraction pocket theory. And because it is a feature of unsafe CSUM, treatment is MRM. Here the treatment was MRM. So colostoma will also be MRM. So these are the features of colostoma that you have to remember. Okay. And then facial palsy or Bell's palsy. When I was talking anatomy, someone was talking about facial palsy. I had mentioned facial palsy. So in anatomy, you don't talk about palsy. Palsy is a disease. Bell's palsy. Bell's palsy is the most common cause of facial palsy. But in Bell's palsy, the treatment is a very, very important MCQ. What is the treatment for Bell's palsy? Steroid mainly for 1 to 2 weeks, plus minus acyclovir. So this is the treatment for Bell's palsy, steroids for 1 to 2 weeks, and we add acyclovir. But the larger question they ask is, if there is no response with steroid and acyclovir, then what do you do? Any idea? If there is no response with steroid or acyclovir, we do something called electroneuronography. And then we do decompression of fascia. So this is the treatment for Bell's palsy. Okay. So we start with steroids. If there is no response, we do a nerve stimulation test. Electroneuronography is a type of nerve stimulation test, and based on the result of nerve stimulation test, we may have to do what is called decompression of the fascia. So this will complete your facial palsy, and then we discuss a very important surgery that is done for otitis media. What is that surgery? A very important surgery that is done for otitis media. That surgery is tympanoplasty. And then we'll talk about mastoidectomy also. 2 surgeries. First, tympanoplasty. Now tympanoplasty, as you can see on your screen, has 5 types. And they ask you the names. Type 1 is called myringoplasty. Type 2 has no name. Type 3 has 2 names, columella and stepidomeringopexy. Columella is a very, very popular MCQ, this one. So columella they really ask you in the exam. So remember, columella is the other name for type 3. Type 4 also has no name. And type 5 is called fenestration surgery. Right. So in tympanoplasty, they ask you the names. And second thing they ask you, where do you place the graft in which type? So in type 1, the graft on malleus, which is the first ossicle, right? In type 2, the graft on incus, which is the second ossicle. And in type 3, graft on stapes, which is the third ossicle. So that's how you know. If you place the graph on the first ossicle, type 1. If you place the graph on the second ossicle, type 2. If you place the graph on third ossicle, type 3. That's how you remember. Type 4, very important. Now in type 4, no ossicle left. Type 4, there are no ossicles left. So where do you place the graph now? So graph over round window. So that's why this can be an important MCQ, because if you know that there are 3 ossicles and in type 4 there is no ossicle, so where do you place the graph? Over the round window. Remember that. And in type 5, it is not about graph. In type 5, we create fistula over lateral semicircular canal. So type 5 is not about graph. In type 5, we create a fistula over the lateral semicircular canal. So Pratisha, you are again wrong. Please make the correction. Yes. Okay. So this is a very, 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 very important slide for you. Extremely important slide. Please spend some time on this slide when you revise. Very important slide. Mastectomy is less important than this one. This is very important, extremely important. Okay. But mastectomy can be simple mastectomy, can be MRM, modified radical mastectomy, and there is a radical mastectomy. Simple, MRM, and radical. Right. Now 2 or 3 questions only from here. Number 1, simple mastectomy has 2 more names. It's called cortical mastectomy. It is called sword surgery. And the most common indication is acute mastoiditis. MRM has 2 subtypes. One is called canal wall up surgery and canal wall down surgery, and all these mastectomies, they are done for unsafe CSU. So you know the names of the mastectomies, you know the indications. And finally, last thing is radical mastectomy has 3 steps, and they ask you, not a very popular question, but once in a while they ask you the 3 steps of radical mastectomy, except all the 3 steps they start with the letter E. So that is an easier way of remembering the 3 steps. If you can remember, there are 3 E's, it is easier. First E stands for the word called exteriorization. Just remember this word. If you know the meaning, well and good, otherwise it is not important. Second, except foot plate. So remember, except foot plate, everything else is removed. The only thing that we don't remove is the foot plate. Everything else is removed, and station tube is blocked. So you have to do these 3 steps in a radical mastoidectomy. Necessary step. Anything else you do is additional. It's not necessary. जो करना ही करना है वो ये 3 है. Baki, there are many things like somebody saying myotoplasty, it is not necessary. Myotoplasty is not a necessary step. Some people do it, some don't do it. Okay. But if you modify any of the three steps, it becomes modified radical. MRM is modified radical, where there is a modification of the radical. So these are the two main surgeries in otitis media that you have to know: mastodectomy and this one, which is called tympanoplasty. But this will complete everything to do with infections of the middle ear. Then we talk about non-infective disease. We talk about these two tumors. Both are benign tumors and both are very, very popular tumors from the exam point of view. But both you have to know 2-3 points. Now, glomus tumor is a type of paraganglioma. Whereas acoustic neuroma is a type of schwannoma. So these are the groups they belong to, right? Glomus tumor, the most common site is fingertip or nail bed, but schwannoma is cerebellopontine angle in inferior vestibular nerve. So this is the site. So we know the type, what category group they belong to. One is paraganglioma, one is schwannoma, and the site. Third point, presentation. Glomus tumor usually is a 50 years old lady with conductive hearing loss plus minus pulsatile tinnitus. In acoustic neuroma, there is tinnitus with sensory neural hearing loss and loss of corneal reflex. This is the presentation of acoustic neuroma: tinnitus, SNHL, and loss of corneal reflex. Then comes this sign. In glomus tumor, there are 4 signs. Rising sun sign, brown sign, Phelps sign, and Aquino sign. In glomus tumor, there is only one sign. In acoustic neuroma, that is called Histelberger sign. Right. Investigation of choice, CECT. In this case, gadolinium MRI. GD stands for gadolinium. So, it is gadolinium MRI. And finally, treatment of choice, embolization and surgical excision. In this case, there are 2 things. You can do surgery, and second treatment is, I am writing the treatment here. Gamma knife radiotherapy. Remember this one, gamma knife radiotherapy is the thing that you have to remember as far as the treatment of acoustic neuroma is concerned. So once again, see one table, total almost 10 points only together, but you complete two important tumors of the ear, and both are very popular tumors. That's why the importance of this session is this, that you may have class notes, you may have studied from some app, some class notes, some lecture, but this is really bringing all the information together in 2.5 hours. Nobody can give you so much information from ENT that I'm going to give you in this lecture. So that's why please stay, make your notes. If you cannot make the notes, don't worry, I'll make a PDF file also at the end. I'll share with the file, and share this with your friends who are appearing. If you are good well-wisher of your friends, please share with your friends. It is going to benefit a lot, and it is going to save a lot of time. And I'll tell you, in the last moment, आपको और कुछ करने की जरूरत नहीं पड़ेगी. Only thing you have to do is revise these notes, nothing else, but revise this many times. Okay. So these are the tumors, and finally non-tumor disease. We're going to discuss 3 diseases. One is autosclerosis. After autosclerosis, I will discuss these 2 diseases also. But first, autosclerosis. Now, autosclerosis is very, very popular disease. I'm sure you know this already, right? So what are the things about autosclerosis that you have to know? Sight. Sight is fenestrum. In the anatomy, I told you fistula and fenestrum. That is the most common sight. But before I proceed, friends, if you have any friend or your colleague who think they could not study, they could not prepare for whatever reasons, or they are not confident, they think I can't do anything now because it is just 1 month from now the exam, कि अब तो कुछ हो ही नहीं सकता, give these notes to them and tell them इसी को बस 3-4 बार पढ़ लो, रट लो, आपका ENT निकल जाएगा, my guarantee. Okay, this is especially for your friends who think कि they have not studied, they don't have time, they are low in confidence, they are like depression all, कि नहीं हो सकता मेरे से. You tell them ENT का solution है, ये notes पकड़ो और इसको 4 बार रिवाइज कर लो, 3 बार, हो गया, ENT निकल जाएगा आपका. Okay. Then cause. Most common cause is measles. Presents. The history looks like this. A 32 years old pregnant lady with conductive hearing loss. This is the usual presentation in this one. So usually the lady is around 30 years, around little bit here and there. She is always pregnant. In this case, it will always be a pregnant lady and conductive hearing loss, always. There are 2 signs, only the names. One is called Swart sign. The other sign is called Paracusis Willisi. Swart sign, Paracusis Willisi. Then Rinne's test will be negative. Galli's test will be negative. Audiometry will show Cahart's notch. Audiometry will show Cahart's notch. And tympanometry will be AS type. Now these last 4 points, very important. They really ask you these 4 points in the exam very, very commonly. Right, very commonly asked. There is a syndrome in autosclerosis called Van der Hoef syndrome. In Van der Hoef syndrome, These are the three features. Okay. And finally, treatment of choice, stapedotomy, and the drug of choice is sodium fluoride. So this slide plus this slide, they include all the important points from a very popular ear disease called otosclerosis, very popular disease. But I want to tell you 1 or 2 points about this very popular surgery called stapedectomy. You have to know the indication. You have to know the common contraindication. You have to know the common complications. Only common, 2 or 3, not all of them. The only indication for stapedectomy surgery is passive stage of otosclerosis. The only indication. What is the contraindication? Active stage is a contraindication. Only hearing ear, and frequent flyers. Actually, there are many contraindications, but I want you to remember 3 only. Active stage, only hearing ear, frequent flyers. And similarly, there are many complications, but I will advise you to remember 3 or 4. Most common complication is sensory neural hearing loss. Then there is perilimb fistula, because of which there can be vertigo, facial palsy. So once again I am telling you, in stapedectomy surgery, there are many contraindications, many complications, but these are the main ones. If you can remember this, by and large, you will have no problem. Okay. Now, I told you, I will show you some images. Now look at these 3 images. This is red and bulging tympanic membrane. The second one is called cartwheel. Appearance on the tympanic membrane. And the last one has a fluid level. I am writing here. Fluid level. So they are all ASOM. These are all images of ASOM. Then these images, this is not important, but this one is retracted tympanic membrane, and this is air bubbles. This is seen in serous otitis media. In serous otitis media, you have these findings. Right. And these are the perforations of the tympanic membrane. This is central perforation. So it is safe CSOM. This is marginal perforation. So it is unsafe CSOM. And this is multiple perforation. Can you tell me multiple perforation? Which disease? You should know this, isn't it? Multiple perforation. Come on, guys. What is it? You answer. Multiple perforation is tuberculosis. Isn't it? We know this. So these are some of the images of the tympanic membrane, and images of the tympanic membrane can sometimes be useful. They are not very commonly asked, but they can be asked sometimes. So yes, you know the answer, tuberculosis. So I have shown you the main images of the membrane that you should know. And then we talk about two important diseases of the inner ear. Meniere's is a very popular disease, but we'll talk about BPPV also. Now Meniere's is also called endolymphatic hydrops. Meniere's is called the endolymphatic hydrops. BPPV has no name. So Meniere's disease has hydrops. This is due to increase endolymph. This is the cause of Meniere's disease, increase endolymph. And BPPV has canalolith in posterior canal. So this is the first thing. What is the problem? The problem is Meniere's has increased endolymph, BPPV has canalolith in the posterior canal. Now this is the problem, guys. The moment I started talking about these diseases, okay, people say that it is endolymphatic hydrops, fluctuating hearing loss. But when you mention Donaldson's line, which is the correct thing to say, but it tells you that you are focusing on things which are not important. Donaldson's line is not important for you. They will never ask you Donaldson's line in your exam, never. So that is a very important thing, because you have to remember so many subjects, 19 subjects, and remember them. So you should know where to focus and what not to waste your time on. Anyways, if you know anything extra, is always useful. There is nothing wrong. Right. Then Meniere's disease presents as fluctuating tinnitus and SNHL and vertigo more than 20 minutes. BPPV has positional vertigo less than 20 seconds. Yes, for NEET PG it is important. For NEET PG it is important, absolutely important. Donaldson's line. Then signs. Signs in Meniere's disease, there is Hennebert sign, there's Tullio's phenomena, there's diplacusis, and there is recruitment. In BPPV there is no sign. No sign in BPPV. Right. Then investigation of choice in Meniere's, electrocochleography. And in electrocochleography, summation potential by action potential has to be more than 40%. This is the criteria on electrocochleography, that summation potential versus action potential in Meniere's disease has to be more than 40%. In this one, there is Dix-Hallpike maneuver. Dix-Hallpike. And finally, the treatment of choice. So I'll write the treatment of, I'll write here. I'll remove all this. Now in Meniere's disease, mainly we have to give drugs. The most important drug of Meniere's is beta histine. There is a device called Meniere's device, and there is a surgery called intratympanic gentamicin, also called medical vestibulectomy. Actually, the treatment of Meniere's is a very big topic, many points, but I am telling the latest and the main things. In BPPV, the treatment most people know is Apley's maneuver. Apley's maneuver is the treatment for BPPV. So this slide, where there is a feature of Meniere's and BPPV, the signs, the investigations, and this slide where it's mainly about treatment, this will complete all the important points about Meniere's disease and BPPV. This is a Dix-Hallpike maneuver. Image, this is Apley's maneuver. And I'll tell you, this slide is a very important slide. Very important slide, this one. Remember this slide, guys. Very commonly asked, these two images. Right. So this will complete inner ear diseases. And finally, 2 or 3 points about cochlear implant. Cochlear implant is a speech processor. And in this implant, the electrodes, which are called stimulator, are implanted through the round window. Into scala tympani. So both these words are very important words. Number one is the round window and second one is the scala tympani. Very popular and very commonly asked. See, in less than 1.5 hours, I've told you all the important points about ear. You go and check in ear. Ear के सारे important points जो आपको पता होना चाहिए, मैंने आपको बता दिए. 1.5 घंटा भी नहीं लगा. Less than 1.5 hours. So this is the importance of the such sessions. This is why DBMCI has these sessions, so that it can give you very concise, crisp thing in a very short duration of time. In the last 1 month, you can revise all these 19 subjects multiple times. Jaldi jaldi. In 1 week, you can revise all the subjects. You know, 2, 3, 4 घंटे के top subjects हैं. And if you revise 3-4 times, they get stuck into your head and you can remember them. Especially those people, again I'm repeating, those who don't have confidence, जिसको लगता है कि मेरे को नहीं आ रहा, I have not studied properly, ये याद नहीं है, ये समझ नहीं आ रहा, it is very useful for those guys. So ear is done, then we start throat, pharynx. Now pharynx, for those who know, I draw like this. This is the face, and now this entire posterior column is the pharynx. This is your nasopharynx. This is your oropharynx. and this is your laryngopharynx. So three parts of the pharynx, as you can see in the image: oropharynx, nasopharynx, laryngopharynx. And laryngopharynx has two parts. The front is larynx, the behind is hypopharynx. Right. Now in the pharynx, there are four tonsils. There is palatine tonsil, there is adenoid. These two are the main tonsils, but two more: tubal tonsil and lingual tonsil. So four tonsils in all. Out of which palatine tonsil is the main tonsil. Now these are the five arteries supplying the palatine tonsil. Very important. Extremely important point. The five arteries that supply the palatine tonsil are: tonsillar branch of facial artery is the main artery, ascending pharyngeal, ascending palatine, descending palatine, and dorsal lingual artery. So artery is important and the nerve is important. Nerve is the ninth nerve. Right. So in the tonsillar anatomy, this is the only important thing. Five arteries, very important. Larynx anatomy, cartilages. Three unpaired, three paired. Unpaired cartilages are cricoid, thyroid, epiglottis. And paired cartilages: arytenoid, cuneiform, corniculate. And from there is a very important MCQ. What is the shape of cricoid? Cricoid is described as signet ring shaped cartilage. The shape of the cricoid is signet ring shaped cartilage. So these are the information of the cartilages. Sometimes they might show you the image like this and you may be asked to identify these cartilages. So this is epiglottis. This is thyroid cartilage and this is cricoid cartilage. These are the three main cartilages that you should be able to identify. Now, other than the three cartilages in this image, you should be able to know this. This is a hyoid bone and this is thyrohyoid membrane. So this is the minimum things in the anatomy of the larynx that you should be able to identify from the ENT point of view. Maybe in anatomy they may teach you other things, but in ENT this is sufficient. Right. Now comes the main anatomy of the larynx. See the movement of the larynx. Larynx has three movements. There is abduction, there is adduction, there is tension. If I ask you, what is the purpose of abduction? How does abduction of the larynx or vocal cord help you? Any idea? Abduction करने से आपको क्या होता है? How does it help you? Anybody wants to answer that question? How does abduction of the vocal cord benefit? It benefits in breathing properly. Abductions helps you breathing properly. How does adduction help you? Abduction helps you in voice production. And come on, who said this prevent the tongue fall? ये कहाँ से आ गया? And how does the tension help us? Tension help us is high pitch voice. Right. So posterior cricoarytenoid, as somebody rightly said, is the only abductor. These are 4 adductors. These are 4 adductors, out of which 3 are main adductors. This is weak adductor. This is main tensor. This is weak tensor. Right. Now, if I remove this name and remove this name from here because they're weak. So, main abductor and adductor. Main adductor and abductor is supplied by recurrent laryngeal nerve. So, recurrent nerve is for breathing and for voice production. Obviously, this is going to help in breathing and in voice production, whereas main tensor is supplied by external laryngeal nerve, a branch of superior laryngeal nerve. Now, you know why this slide is so important. If they ask you, mind my words, if they ask you the question from the anatomy of the larynx, 80% question will come from this slide only, 80% of the time. If you can check in the last 10 years or 20 years, if they've asked 10 questions from the anatomy of the larynx, 10 questions, 8 are from this slide only. What is this slide telling you? This slide is telling you the muscles, their functions, and their nerve supply. Right. So remember that. And these 2 main nerves, that is recurrent nerve and superior nerve, both are branches of vagus nerve, which is the 10th nerve. So now comes very important thing. See, nerve of larynx. The only nerve in the larynx is vagus or 10th nerve. There is no other nerve in the larynx. But vagus or 10th supplies the larynx via 2 branches, superior laryngeal nerve and recurrent laryngeal nerve. 2 branches of the vagus in the larynx, superior and recurrent. Superior has internal laryngeal nerve and external laryngeal nerve. Vagus, recurrent remains recurrent laryngeal nerve. It has no branches. So eventually in the larynx, we have 3 nerves eventually. Now comes very, very important point. What I'm going to write now is going to be the question that they ask you in the exam very commonly. The question they ask you is, what is the main symptom if this one is damaged? If only internal is gone, what is the main symptom? Any idea? The main symptom when only the internal nerve is damaged is aspiration. So if they tell you the patient complains of aspiration, which nerve is damaged? Internal laryngeal nerve. And if the external is damaged, then what is the main symptom? If the external is damaged, then the main symptom is low pitch voice. With loose vocal cord. If the patient has low pitch voice and loose vocal cord only, then external is gone. No hoarseness. No hoarseness. Don't, please be sure. If the patient has both the symptom together, this plus this, then it is superior laryngeal nerve. If the superior is gone, then you have this one plus this one. And what will happen if the recurrent is gone? Any idea? If recurrent is gone, the symptom depends whether it's unilateral damage or bilateral damage. If it is unilateral recurrent nerve damage, then hoarseness is the main symptom. Hoarseness. And if it is bilateral, then dyspnea is the main symptom. So from this particular slide, I don't know how many times they have asked the question. How do they ask the question? They will usually give you the symptom, either dyspnea or hoarseness or low pitch voice or aspiration or a combination, and then they ask you which nerve is damaged. The answer will come from here. So this slide is in, and the previous one, this slide, this one and this one, I can't tell you how important these two slides are. Right. Now treatment we'll discuss. We are still continuing the anatomy. In the disease we'll discuss. So now we start with the diseases of the ear, of the throat. The first disease we'll discuss, which is not a very popular disease, is adenoid phases, which is due to adenoid hypertrophy. So remember this, adenoid phases happens due to adenoid hypertrophy, has 5 features, and they ask you this very commonly: high arched palate, prominent upper teeth and crowded upper teeth, pinched nose or collapsed ala, hypoplastic maxilla, dull expression. Just remember that, nothing else. Now many of you are asking questions related to vocal cord palsy. How do you treat palsy? What thyroidectomy में क्या होगा? All this I'm going to do now. Vocal cord palsy नहीं किया अभी. We have done the anatomy part. We'll discuss the palsy part. So we'll answer those questions. Okay. Now comes tonsillitis. Types. Catarrhal tonsillitis, follicular tonsillitis, membranous parenchymatous and fibrinoid tonsillitis. These are the 5 types of tonsillitis. The first one is caused by adenovirus, and this is the most common type. And these 3 are caused by strep pyogenes, this is very rare. Right. So these are the few points about tonsillitis, and then we talk about tonsillectomy. Most common indication: 2, recurrent tonsillitis and chronic tonsillitis. Then you can remember quinsy also, right? So the list is very long, but I have told you the most common indication only. And most common contraindication, again it's a long list, I will tell you 2 only. Which are the 2? That bleeding disorders and cleft palate. Most common complication, bleeding. So these are some of the most commons of tonsillectomy surgery, the most common indication, the most common contraindication and most common complications. Okay. Now bleeding is very important. Bleeding. Before I talk about bleeding, best method of doing tonsillectomy surgery, one is you can do snare, which is very popular, and second method is coablation. So I've told you some of the very important points regarding tonsillectomy surgery. This is equally important for NEET PG. All this NEET PG में तो कुछ भी आ सकता. So this is important for NEET PG. This is important for FMG. Everything. Now bleeding is very important. Now bleeding of tonsillectomy, as you can see here, can be primary bleeding, reactionary bleeding, and secondary bleeding. Now I will not tell you the details of bleeding. Primary bleeding is from paratonsillar plexus of veins. This is the source of primary bleeding. It happens from the paratonsillar plexus of veins, and the treatment is apply pressure for 5 to 10 minutes. If this fails, do cautery. If this fails, ligation. So these are the things that you have to know about primary bleeding, which, as somebody rightly said, happens during surgery. Reactionary bleeding is due to slippage of ligature, and this is always sudden and severe, and so it is dangerous. Because it is sudden and severe, it is dangerous. And what is the treatment? Immediate religation in OT under general anesthesia. Duration is not important for you guys, but still, since you have asked duration, I'll tell you. Primary bleeding during surgery. Reactionary bleeding within 24 hours. And secondary bleeding usually 5th to 8th day of surgery. So primary bleeding is during the surgery, secondary bleeding is within 24 hours of surgery, and reactionary bleeding happens 5 to 8 days due to infection, and so mainly antibiotics. So this is the information about bleeding during tonsillectomy surgery. So this slide is a very, very important slide. If they ask you a question from tonsillectomy surgery, it is mainly going to be this slide. Okay, this is mainly going to be this particular slide if they ask you a question from tonsillectomy surgery. Now the three images which are very important, these three images. Quinsy, where the tonsil is enlarged up to uvula. Ludus angina, there is a swelling in the floor, and ranula. This is ranula, and this is Ludwig's angina. So please make the correction. Now in quinsy, you have to know 2 or 3 points. Number 1, it is caused by strep pyogen. It is called hot potato condition. But treatment is the most important thing they ask you in quinsy. Immediate IND with interval tonsillectomy. So the treatment is very important. When they ask you the treatment of quinsy, you have to say the whole thing. Immediate IND and interval tonsillectomy. Quinsy is also called peritonsillar abscess. Quinsy, peritonsillar abscess, quince. In ranula, only the image is important and the treatment, marsupialization. This is the only important thing in ranula, the image and marsupialization. Lutis angina, again treatment is important, IND plus antibiotics. In all these three diseases that you see on a screen, the main thing which is very important are the images. Images are important, right? So this will complete the main disease of the nasopharynx and oropharynx. We have not discussed the tumors. Tumors we'll discuss a bit later. Before we start talking about tumors, let me tell you few important diseases from the larynx. Larynx is very important. Laryngomalacia. How does the laryngomalacia present? A newborn child with inspiratory stridor. This is how the child present. A newborn child with inspiratory stridor. On examination, this omega shaped epiglottis, which is seen in the image like this. And treatment, reassurance. That's all in quinsy, in laryngomalacia. Okay. Now, before I go to the next topic, somebody has asked me about difference between quinsy versus parapharyngeal space abscess. So let me tell you the difference between clinical difference. Both have fever and sore throat. This also has fever and sore throat. So symptom is same. Both have, on examination, tonsil post medially up to uvula. This is tonsil post medially, but may not be up to uvula. So that line is very important. This one has no neck swelling. Neck swelling, which is called fullness behind angle of mandible. Right. So this is the difference in the clinical presentation of quinsy and parapharyngeal space abscess. So quinsy has tonsil up to uvula, and in parapharyngeal space there is a swelling behind the angle of the mandible. This is the main clinical difference. Right. Then we talk about vocal cord palsy. We discuss this one. Most common cause 2. Most common tumor causing vocal palsy. So overall, most common cause of vocal cord palsy, idiopathic and thyroidectomy. But if they ask me which is the most common tumor that causes vocal cord palsy, then it is bronchogenic carcinoma. So coming back to this one, treatment, I told you in this one, this is the treatment. Now, vocal cord palsy are two main types. Which are the two main types? Abductor palsy due to recurrent nerve damage and adductor palsy due to vagus damage. So this is the first thing they ask you. If recurrent nerve damage, which type of palsy? Then you say if the recurrent nerve is damaged, it is abductor palsy. And if vagus is damaged, what type of palsy? Then it is adductor palsy. So that is the first thing. What is the position of the vocal cord? The position is paramedian position. And in this case, the position is cadaveric position. Okay. So you know the name of the palsy, the nerve damage, and you know the position. Now in each of them, it can be unilateral palsy or bilateral palsy. So we divide into two groups. This one also unilateral palsy and bilateral palsy, and we divide into two groups. In unilateral palsy, the main symptom is hoarseness, and this becomes normal without any treatment. So no surgery required. Obviously, a thing that will become normal on its own, then why will I do any surgery? In bilateral palsy, dyspnea is the main complaint with good voice. See, I am not saying the voice is normal, it is good voice. What are the surgeries we do? We can do tracheostomy, we can do type 2 thyroplasty, which is also called lateralization of vocal cord. There is a very popular surgery called Kashima's operation. Kashima's surgery, and there is chordoplasty. So in bilateral abductor palsy, you have to remember the name of 4 possible surgeries we may have to do: tracheostomy, type 2 thyroplasty, Kashima's, and chordoplasty. In bilateral abductor palsy, unilateral abductor palsy, hoarseness is the main complaint, and the surgery we do is type 1 thyroplasty. In type 1 thyroplasty, there is medialization of the vocal cord. Medialization of the vocal cord is done in type 1 thyroplasty. And in the last one, there is aspiration and aphonia. And you can do diversion surgery. You can do total laryngectomy. Right. So this will complete the main points about vocal cord paralysis. In vocal cord paralysis, they don't ask you which nerve and all that thing. They don't ask you easily. This is what they ask you. Types of palsy, which palsy is caused by which nerve damage, what is the main symptom, what is the position of the vocal cord, what is the surgery you will do in this particular palsy. All this is what they ask you. So don't spend your time trying to mug up useless stuff which they don't ask you in the exam anymore. So don't waste your time, guys. In vocal cord palsy, this is the slide that you have to know properly, absolutely. Okay. Now thyroplasty, I have told you type 1, I have told you type 2, but they are type 3 and type 4 also. So this table, which is telling you about all the 4 types of thyroplasty, and it's a very, very important topic. From here, they really ask you questions. So in this slide, it is talking about all the 4 types of thyroplasties. What is done in type 1, medialization. What is the main indication, unilateral adductor palsy. What is the outcome? It will improve the voice. What is type 2 thyroplasty, lateralization. What is the main indication, bilateral abductor palsy. What is the outcome? It relieves dyspnea. Type 3, we shorten or loosen the vocal cord. What is the indication? Pure phonia. What is the outcome? It will decrease the pitch of the voice. And type 4, we lengthen or tense the vocal cord. What is the indication? Androphonia, and it will decrease the pitch. So this slide is also very important. Now we talk about inflammatory disease of the larynx, infections. Now the 2 important inflammatory diseases of the larynx, epiglottitis and croup. Once again we will compare the 2, and you will see that if we compare them, it becomes very important. Epiglottitis caused by strep pyogenes. Croup is caused by parainfluenza virus. Epiglottitis is seen, average age of the child is 5 years. This is less than 3 years. Now comes the important thing. Presentation. Presents fever, dyspnea, dysphagia. This one also has fever, dyspnea. These 2 are things same, but voice change. So fever is seen in both, dyspnea is seen in both, dysphagia versus voice change. Now comes the main thing which everybody knows, X-ray, thumb sign, and this is steeple sign. Everybody knows this, thumb sign and steeple sign. And drug of choice, 3rd generation, cephalosporin. In this treatment, we do 3 things. If we give steroid, we do nebulization, and we give antibiotics. Now these are the main things about epiglottitis and croup, right? But what they ask you are these two images, thumb sign and steeple sign. These two very, very important images. Very important slide. They really ask you questions from here, thumb sign and steeple sign. Please be able to identify these two images very nicely. And then tuberculosis. In tuberculosis, two things. Most common site of laryngeal tuberculosis, posterior part of glottis. So it is seen in the posterior part of the glottis. And on examination, there are three findings. They are described as terpen epiglottis, mouse nibbled appearance, and cobblestone. Treatment is ATT, of course, but this is important MCQ. So tuberculosis of the larynx is a very simple topic, few points only, but try to remember these few things, very important. So these are the inflammations of the larynx, and finally in the larynx, few important growths. So which are the growths that we will discuss in the larynx? We'll discuss vocal cord nodule polyp. We'll discuss Rinke's edema, laryngocele intubation granuloma, two benign tumors, JNA and papilloma, and two carcinomas. So a lot of growths, but few points. Now both nodule and polyp are caused by chronic misuse of voice. Nodule is called singer's nodule. The site is the same. They are both seen at the junction of anterior 1/3 and posterior 2/3 of vocal cord. The site is the same, and both present mainly as hoarseness plus minus diplophonia. The main difference, treatment of choice in nodule is voice rest, and treatment of choice in polyp is microlaryngeal surgery. Guys, I am going fast so that I can cover the maximum amount of point in the minimum amount of time. I produce lot of charts and tables so that you can really revise a lot of things in the minimum amount of time. And even if you are missing something, that means because I'm going to give you the PDF file of this, then you can, go and check on the PDF file if you miss something. So very useful it should be. And waste of time is useless. Don't waste your time in useless thing. Only 1 month left. You don't have too much time. Now again, Rinke's edema, edema of the Rinke space. Yes, in this case you can say plus PPI. In this also plus PPI, proton pump inhibitors can be given to both these patients, but that is less important. Now Rinke's edema, the only thing you have to know is the treatment is conservative, but second line is microflap technique surgery, or you can do stripping of the vocal cord. In laryngocele, the only thing you have to know that it presents as hoarseness in trumpet blower with neck swelling and treatment again conservative. Treatment is again conservative. In intubation granuloma, obviously the cause is long-term intubation. That is one thing you have to know, long-term intubation. You also have to know the site. This time the site is opposite of nodule polyp. It is junction of anterior 2/3 and posterior 1/3. If you remember, in nodule polyp, I said junction of anterior 1/3 and posterior 2/3. Yes or no? And here I am telling you the reverse of that. Junction of anterior 2/3 and posterior 1/3, and treatment. We have to do many things in nodule in intubation granuloma. We have to do, I am writing here, CO2 laser plus Botox plus mitomycin C plus steroids. So you have to do 4 things in intubation granuloma. You have to do the surgery called CO2 laser. You have to give steroids. You have to give Botox. You have to give mitomycin C. Right. So these are the points about these 3 growths of the larynx. Then we will discuss 2 benign growths, JNA and laryngeal papilloma. I hope you know the full form of JNA. I don't have to tell you. Site. Sphenopalatine foramen, and this is glottis. Present. A 13 years old boy with recurrent epistaxis. If you have similar to this a history, it's a boy, male child, around 13, 14, 15, 16 years old with epistaxis, this is the only possible disease. A child with hoarseness. Two signs. Antral sign, frog face, no sign. In that case, no sign. Now, treatment. Embolization followed by surgical Now, papilloma multiple excision with micro debridement plus cidofovir inside the lesion plus interferons. Right. Now in this, I've left the most important information for the last thing. Cause of laryngeal papilloma is human papillomavirus 6 and human papillomavirus 11. Very, very important MC. So these are the two benign tumors where you know the site, the presentation, signs, cause, treatment, and few important images if they are necessary. And finally, carcinoma. Nasopharyngeal carcinoma is more important for you as compared to laryngeal carcinoma. In nasopharyngeal carcinoma, you have to know 5 points. In laryngeal carcinoma, you have to know 1 point only. Site. What is the site? Fossa of Rosenmuller. Which virus? Epstein-Barr virus. Most common presentation? Cervical lymphadenopathy and Trotter's triad. These are the two important presentations, cervical lymphadenopathy and Trotter's triad. In Trotter's triad, there are three things: hearing loss, short palate palsy, facial pain. And treatment of choice, chemo radiation. Now in nasopharyngeal carcinoma, in laryngeal carcinoma, I will only tell you the treatment, nothing else. And treatment depends on stage 1, stage 2, stage 3, stage 4A, 4B, and 4C. In stage 1 and stage 2, new answer and old answer. What is the new answer? The new answer is transoral laser microsurgery. What is the old answer? Radiotherapy. So you have new answer, you have old answer. Same thing for these three. What is the new answer and what is the old answer? New answer is concurrent chemoradiation, but the old answer is laryngectomy followed by radiotherapy. In 4C, So in laryngeal carcinoma, as you have seen, that I've already told you the treatment that depends on the stage, and I've given you the new answer. If new answer is not given, you can look for the old answer also. And it is a very common question they ask you. This is the only thing in laryngeal carcinoma that is commonly asked. But in nasopharyngeal carcinoma, you have to know the site, the virus, the main presentation, Trotter's triad, chemo, radiation, the treatment of choice. Everything is important in laryngeal carcinoma. So this will complete all the important growths of the larynx that you have to know. So this by and large completes the throat. But in throat, two more things. 1 or 2 points about tracheostomy. The most common indication is laryngeal block due to laryngeal carcinoma. This is the most common cause. Larynx is blocked due to laryngeal carcinoma. Site. Ring 2 and ring 3. If you do tracheostomy in ring 1, it becomes high tracheostomy. And high tracheostomy is done for laryngeal carcinoma only. There is no other indication for high tracheostomy except laryngeal carcinoma. And most common complication dislodgement of tube, bleeding, and subcutaneous emphysema. So these are the only important points that you have to know in tracheostomy. But lot of people cannot identify the tube. These are tracheostomy tubes. So you should be able to identify the tracheostomy tubes. And these are valves that are used for speech rehabilitation. So because I'm going to give you the PDF, you'll get the images. So don't worry, I'm not going to wait here. And the last question in the throat, you will answer. Where is the foreign body in the first one? Where is the foreign body in the second one? First one, where is the foreign coin? Where is the coin in the first image? You want to answer this question? I'll wait for your answer. Coin in the first image and coin in the second image, guys. What do you say? Yes, the first one is esophagus, BPR, dermis, and the second one is either larynx or trachea. Correct. So this completes throat. See how much time we take throat? Only 1 hour, throat is complete. The whole throat, nasopharynx, oropharynx, larynx, tracheostomy, speech, rehabilitation, foreign body, everything is complete in 1 hour. And finally, nose and sinuses. right? In nose and sinuses, this is nasal septum, and this is the lateral wall of nose. So basically, these are the images they ask you in the nose to identify sometimes. The names are given there of the main things, so it's not difficult. Just look at the name and try to remember them. But arteries of the septum. These three carries blood so the first three carries the blood from the external carotid. The last two, they carry the blood from internal carotid. So these are the 5 arteries. These 4 they form Kisselbeck's plexus, Little's area, most common site of epistaxis. Everybody knows this. It's a common knowledge. I have to tell you, it is not required because most people know this anyways. Now, epistaxis, most common site or Little's area, most common artery that bleeds is the most common cause, 2 causes. Most common cause is idiopathic. Now, these are very common knowledge. I shouldn't even tell you because I don't think there is anybody who is preparing for the exam and does not know all this. Everybody knows. Treatment. Nose pinching. If this fails, cautery with silver nitrate. It's a very important MCQ. If this fails, nasal packing. If this fails, ligation of sphenoplatean artery. If this fails, And this is a very commonly asked question, the last point. If the ligation of external carotid fails to stop the bleed, what do you do? And the answer is ligation of anti-ethmoidal artery. So although this slide is a very simple topic, most people know everything, but be very sure, because this is a very important topic. They ask you a lot of questions from here and nobody gets this wrong. So you have to get it right every time they ask you questions from here. Okay. That's why I've given you this. So this is epistaxis. Then few types of rhinosinusitis. Right. In this rhinosinusitis, in allergic rhinitis, you have to know most common allergen is house dust. Most common allergen is house dust. In vasomotor rhinitis, one of the treatment is Vedian neurectomy. Now, Vedian neurectomy is a treatment of a vasomotor rhinitis, is a very, very important MCQ. Very important point, very important MCQ. So, try and remember this. And now we come to two rhinitis, which is the most commonly asked. Atrophic rhinitis, very important topic, but only 5 points about atrophic rhinitis. It has another name. What is the other name? Oziana is the other name. Most common cause, decreased estrogen is the most common cause. Which are the main features of atrophic rhinitis? Roomy cavity, dry cavity, crust formation, foul smell from the nose, anosmia. They are the main features. Presents nasal block is most common presentation, and merciful anosmia. Now, merciful anosmia is a very important topic. Merciful anosmia, very, very important topic of atrophic rhinitis, merciful anosmia. Treatment. Alkaline nasal douche plus minus surgeries. So, alkaline nasal douche contains 3 salts of sodium. Sodium's BBC. So, first B is bicarbonate, biborate, and chloride. So, we have sodium bicarbonate, sodium biborate, sodium chloride. And which are the surgeries? Young's operation, modified Young's operation, Lawton-Slaker surgery. right? Young's operation, modified Young's operation, and Lawton's-Leger surgery. Okay. Out of all the rhinitis, atrophic rhinitis is the most important rhinitis for you from the exam point of view. So very, very important, this one, this slide and this slide. Then we'll talk about few points about fungal rhinosinusitis. So there are 4 types of fungal diseases that you can see on your screen: aspergillosis, fulminant fungal sinusitis, mucormycosis, and allergic fungal sinusitis. It is called by Aspergillus fumigatus, and this is the most common type, and it forms aspergilloma. Right. This is caused by, again, Aspergillus fumigatus, and this is caused by a rhizopus. Now this is called black fungus. Both are seen in people who have diabetic who have received steroid. They're invasive, and the drug of choice in both is liposomal amphotericin B, and this is how the black fungus looks like. You can see the skin on the nose is deep black, and that is called black fungus. Now, allergic fungal sinusitis has major criteria. Major criteria for diagnosis of allergic fungal sinusitis: it is type 1 hypersensitivity. It has a type 1 hypersensitivity. Second point, it has nasal polyps. Third point, CT scan will show double density scan. Fourth point, mucin has eosinophils, and mucin of the nose has fungus. So these are the 5 criteria, as Pratyusha is saying correctly, that these are Bent and Kuhn criteria. These are criteria by Bent and Kuhn. Bent and Kuhn criteria. So double density scan is a very important scan. This is double density. Right. So these are the main types of fungal rhinosinusitis that you have to know. In one slide, I've given you all the important information that you have to know. So it's not going to waste too much of time. The two main images of this disease is also shown here, double density scan and black fungus. But if I ask you, which is the most common X-ray view for sinuses? The most common X-ray view for sinuses is, anybody wants to answer that question? Occipito mental view is the most common view. Now, occipito mental view can be done by two methods: with closed mouth of the patient, with open mouth of the patient. With closed mouth, it is called Waters view. With open mouth, it's called Pierre's view. Waters view is only for maxilla. Pierre's view is for maxilla and sphenoid. Right. Now, somebody has written, Pratisha, that lateral view is for all the sinuses is not true. Lateral view for all the sinuses is not true. It is not a correct information. You can say 50-50% true. It is not absolute truth. Okay, so please bear in mind. Now, in sinuses X-ray, you should be able to identify 3 axes only. Don't try to identify 10-15 axes that are given in your books. No, don't waste your time. Only 3. There is 3. This is Waters view. This is Pierre's view. This is Cardwell's view for frontal sinus. Only 3 views. Don't waste your time trying to read and identify other X-ray view, because time is very important for you. If you know this slide and this slide, X-ray of the sinuses, done. Done means done. My guarantee. Okay? Don't waste your time. And then DNS, deviated nasal septum. Most common cause, birth trauma. Most common presentation, nasal block. Nasal block due to DNS, Townes is mastoid. Townes view is mastoid. That's why I tell you, you don't have to know unnecessary information. दिमाग occupy हो जाता है, and then you lose sight of main things. Now, mainly on same side, sometimes on opposite side. Now we all know opposite side is due to compensatory hypertrophy of inferior turbinate. This everybody knows, right? and headache of DNS is called, if the headache of DNS, it is called anti-ethmoidal syndrome. If you want to do any test, you can do Cottel's test, but Cottel's test is not done in practice because it is not useful, but in the exam they ask you sometimes. Treatment of choice, septoplasty, or you can do submucosal resection. In septoplasty, we apply Freer's incision. In SMR, Killian's incision. So this one slide carries all the important information about DNS. Or this is or, either septoplasty or SMR, not both. Okay, so this slide carries all the important information from DNS that you have to know. Then nasal polyps. Nasal polyps have poor blood and poor nerve supply. Because of poor blood supply, they are pale in color, they do not bleed, and they are painless because of poor nerve supply. So these are the properties of polyp. But in nasal polyp, the most important question are the three syndromes. Very important. Very important, these three syndromes. In nasal polyps, don't try to read anything except the three syndromes, right, and their features. Enteroconal polyp and ethmoidal polyp. In children, single and unilateral polyp. Treatment, antibiotic plus FES surgery. I am sure you know the meaning of FES. FES stands for functional endoscopic sinus surgery. Functional endoscopic sinus surgery. Ethmoidal polyp in adults, it is multiple, bilateral and recurrent. Multiple, bilateral and recurrent. And treatment, steroid plus facets. Now these are the main difference between the anterocornal polyp of the nose and ethmoidal polyp of the nose. But the differences are not that important from the exam point of view. What is important in this slide are the three syndromes: Samter's triad, 3 features; Carter-Gainer syndrome, 3 features; Young syndrome, 3 features. These are very, very important points. Okay. Then there are 4 diseases, 3 diseases with a similar sounding name. Rhinophyma is called potato nose. The image is very important. Rhinophyma image is very, very important. Rhinoscleroma is called woody nose. Cause: it is caused by Klebsiella rhinoscleromatis. The histopathology finding is mucous cell and Russell body, and treatment, drug of choice, plus so in rhinoscleroma, these are the 4 points you have to know. You have to know the other name, which is called woody nose. You have to know the name of the pathogen called Klebsiella rhinoscleromatis. The histopathology is mucous cell and Russell body, and the drug of choice is streptomycin along with cautery excision. Rhinosporidisis is caused by Rhinosporidium sebarii, which is an aquatic protozoa. Now the only important question from here is, on examination it is looking like strawberry polyp. Very important MCQ. Strawberry polyp is the other name for this disease. Look at the image given below, deep red in color. Treatment, drug of choice. What is the drug of choice? Dapsone plus okay. So these 3 topics are very simple topics. The 2 images given, both the images are very important, but everything is important here. This is a very simple but very important topic for you from the exam point of view. Right. This should by and large complete all the important infections of the nose that you have to know. Infections. Now about fracture, 2 things. Septal fracture are 2 types. Cevolate fracture and Jarjavi fracture. Severe fracture is vertical, Jarjavi is horizontal. And the treatment is close reduction. Close reduction. And fracture of maxilla are called Lee-Ford fracture. Lee-Ford 1, Lee-Ford 2 and Lee-Ford 3. Lee-Ford 1 is horizontal fracture of maxilla. Lee-Ford 2 is pyramidal fracture. And Lee-Ford 3 is called craniofacial disjunction. So these are some of the fractures of the nose and the sinuses that you can try and remember. But the most important fracture from ENT that they ask in the exam is the fracture that causes CSF rhinorrhea. This is important. This is very important. This is due to fracture of cribriform plate, trauma. There are some signs in this. Target sign, also called halo sign. There is a sign in this fracture called target sign or halo sign. And then beta 2 transferrin is the most specific indicator. Beta 2 transferrin is the most specific indicator of this. Investigation of choice, HRCT. What is HRCT? High resonance CT scan. HRCT is high resonance CT scan. Treatment, conservative. Conservative is bed rest with head up. So this is the most important fracture of ENT that they ask in the exam. And finally, two tumors. Inverted papilloma. Inverted papilloma is the most popular tumor of the nose and the sinuses that they ask in the exam, but only 4 points. What are the 4 points? One is the other name. What is the other name? It's called Ringer's tumor. This is one name. This tumor it's a benign tumor with malignant potential. So this is a tumor which has malignant potential. That's why it's a benign tumor that can convert into malignancy. And the third is treatment. You can say excision with wide margin or medial maxillectomy, not lateral. Not lateral maxillectomy, Pratusha, medial maxillectomy. And the fourth thing which is important are the images that are shown. X-ray and MRI shown below, the images are important. So what are the 4 points? The name, the fact that it has malignant potential, and the treatment, and the CT scan and the MRI. Right. And 2 or 3 points. Esthesioneuroblastoma, they ask you site. It arises from olfactory epithelium in roof of nose. This is the image of esthesioneuroblastoma. And sinonasal carcinoma, 3 points. Most common site, maxilla. Second most common site, ethmoid. Now, ethmoidal carcinoma, 2 points. It is adenocarcinoma. They ask you this. The type of carcinoma seen in ethmoid, adenocarcinoma, and this is seen in woodworkers. It is seen in woodworkers. Now comes very important point, on grains line. When you draw a line from medial canthus of the eye to angle of mandible, this image is showing you the on grains line. On grains line divides the maxilla. This is the maxilla. Into suprastructure and infrastructure. Suprastructure has poor prognosis. This one has good prognosis. And treatment, surgery followed by radiotherapy. So this is a slide that gives you 2 or 3 very important pertinent points about sinonasal carcinoma that you have to know. So this tumor, and this is the most important tumor of the nose that you have to know. This and this. See, in 35 minutes, nose and sinuses complete. So in about 3 hours, I'm guaranteeing you, I've given you all the important points about ENT that you have to know. So my suggestion as far as ENT is concerned, in the last 1 odd month, little more than 1 month, is that don't read any other thing from ENT, just read today's notes multiple times and do some MCQs. MCQs are important. Without MCQs, it is not easy, right? So I hope this session was useful, guys. I really enjoyed taking this session. जल्दी फटाफट पढ़ाने में बहुत मजा आता. No useless talk, nothing. No spending time in useless things. So it's very useful. So I hope you enjoyed and you found this session very useful, share this with your friends. Now you can write this number if you have to ask any question regarding ENT. You can contact me, but I'm giving you this number for another reason. I want a request that after the exam, please share all the questions on this number on WhatsApp. Please share the questions so that I can tell you the answer. I can take a post class exam session where I can tell you the recall questions and give you the correct answers. That is only useful if you give me the questions. That's why I'm giving the number. So God bless you guys. Thank you for joining and best of luck in anything that you do in future. Really, I hope that you really come out with flying colors in every exam that you write. So thank you. But where should I share this PDF file? On what platform? I will make a PDF file. I'll give you one. I'll send it to the technical team and they will share with you on whatever platform that is available. I don't know which platform. Okay. I will make a PDF file. I will send it to the technical groups and they will share with you in whatever platform they feel is correct. Okay. Or if you have the link of that group, send me the link. Send me the link. I will send in that link. So once again, God bless. Take care. Ciao, guys.